So we can start this session, and the very first question is about elderly patient presenting with erythematous silvery scales, the scaly plaques over trunk and extremities for last 10 years. These are occasionally itchy and they show remission, relapse with exacerbations during winters. So most likely diagnosis. Yes, all of you are correct. So I would like to just add a few words, like the word erythematous means redness, right? And silvery scales, classical picture for psoriasis. Apart from that, what you will find few word remission. Now, anyone, what do we mean by remission? Improvement in a condition. So patient will feel that I am cured. So improvement in condition. And what does this word relapse means? Relapse means again worsening of the condition. So if you find the word remission or relapse, it means the condition is improving over some period of time, then again the condition recurs, and exacerbation means flaring up of symptoms. So these are few words which you should know, and of course this is a very classical picture of psoriasis, where you can see the lesions over the extensor aspect. So you can see the lesions are over the extensor aspect, can be extensor aspect of forearm or back, right? The extensor aspect is one thing. Then second is, of course, there is a silvery scales, right? Then third is there is erythematous, means there is a redness around those scales. So this is a classical, spot diagnosis for psoriasis. So yes, the answer is psoriasis vulgaris. Then coming to the next question, tense blisters on flexor surfaces with anti-BPAG1 and anti-BPAG2 antibodies. This suggests the diagnosis of. Very good, Raghu. Very good. Yes. Neha, Priyanka. Fine. This is bullous pemphigoid. Now, for bullous pemphigoid, you have to remember few words. Again, the classical and the most important word is tense bully. Always remember tense bully. Now, what is this bully? Because there are two words, vesicles. There are two words you need to remember, and actually they differ in the size. So bulli are more than 1 centimeter in diameter, vesicles are less than 1 centimeter, and they are both clear fluid containing in lesions. So vesicles bully, they are almost same pathology, but they just differ in size. So if you are having this word, it means the size of the fluid filled lesion is more than 1 centimeter, right? Then the other thing, it's like quite, if you see BP here, the BP word is actually bullous pemphigoid. So that also helps you in making the diagnosis of bullous pemphigoid. So there are antibodies against BPAG1 and BPAG2. Then another thing which you should know here is that there is a clinical sign known as Nikolsky sign. And any idea what is Nikolsky sign? Like it's positive or negative here? Very good, Raghu. It is negative in tense blisters, that is bullous pemphigoid, right? So it is negative. Now, any idea what is Nikolsky sign? Yes, Aninda, Neha, you're right. Rinkesh, you are right. So if we give a tangential pressure along the blisters, there is peeling of skin, right? And this Nikolsky sign is actually a clinical demonstration of acantholysis. It is clinical demonstration of acantholysis. Yes, Raghu, you are absolutely right. Okay. So Nikolsky sign is negative. Now, third thing which you know here is, what if we do immunofluorescence? What we see on immunofluorescence? Any idea? You will see linear deposits of IgG C3, right? So there is linear deposits of IgG and C3. So these are three facts which you should know for bullous pemphigoid. And of course, there are antibodies against BPAG1, BPAG2. And since it is a blistering disease, what is the IgG? Now, since it is a blistering disease, so what is the level of blister formation? It is dermo-epidermal junction. Yeah. So at the junction of dermis and epidermis. So if I draw it something like this, suppose this is dermis, and if this is epidermis, pardon, and here we have dermis, then the blistering is somewhere here, right? Somewhere here at the dermo-epidermal junction. Now, why I'm putting these? Yes, Gulshan, subepidermal, very good. So it is, yes, you can say it subepidermal, below the epidermis. Perfect. Now, why I'm putting all those 4 points? Because these points are very valuable in differentiating bullous pemphigoid from which condition has to be differentiated from bullous pemphigoid? That is pemphigus, and especially I'll be more interested in discussing pemphigus vulgaris. So pemphigus vulgaris. Now in pemphigus vulgaris, what kind of bully will you see? Flaccid bully. Right? In pemphigus vulgaris, right. So flaccid bully. So one thing, tense bully, bullous pemphigoid, and flaccid bully in pemphigus vulgaris. Number 2, now coming to Nikolsky sign. What will be the Nikolsky sign? Yes, Gulshan, right? We will come to that. What the Nikolsky sign is? Positive. Yes, so Nikolsky sign is positive, and as I told you, that is a clinical demonstration of the process of acantholysis. We will come to that later on. Now, what? Yes, very good, Raghu. On immunofluorescence, we will see fishnet pattern. Very good. Fishnet pattern of deposition of IgG, and very good. And what is the level of blistering? Yes, Raghu, absolutely. So this is suprabasal, or you can say intraepidermal. Okay. So there is suprabasal or epidermal acantholysis, right? So if I draw in case of pemphigus vulgaris, the blistering will be somewhere here. This is for pemphigus vulgaris, and this one is for bullous pemphigoid. Clear? So you can see the level of blistering. Yes, intraepidermal. So these are few differentiating points in bullous pemphigoid and pemphigus vulgaris. Apart from these 4 points, there are few other things which you should know for pemphigus vulgaris. Number 1, another thing, like on histopathology, you will see row of tombstones, row of tombstone appearance. And actually what happens, like we are saying that there is suprabasal split. So what happens, suppose if this is the basal layer of epidermis, the basal cells, they remain attached somewhat like this, and this gives rise to the row of tombstone appearance. This is row of tombstone's appearance, and just above that we have all, you can say, acantholysis or blistering. So this is row of tombstone. Apart from that, you should also know what kind of antibodies we see in a case of pemphigus vulgaris. Any idea what? Yes, Raghu, there is mucosal involvement as well. So what kind of antibodies you see? Because in bullous pemphigoid we see anti-BP AG1 and AG2. Very good. So there are actually anti-desmoglein antibodies. So there are anti-desmoglein antibody, yes, anti-DSG3, and this desmoglein is a protein. It's the protein which is present in the desmosome. It is present in desmosomes. Yes, DSG3, totally right. So this desmosomes, actually it is the connecting protein which is within the keratinocytes. Suppose if these are keratinocytes, yes, so there is a connecting protein between the keratinocytes, and this holds the epidermal cells together. Now what happens? Now this is desmosome, and within this desmosome is the desmoglein protein. So if there is any antibody against desmoglein, actually it is going to break the desmosomes as such. What will happen once the desmosomes is broken? What will happen? The cells, they will move apart, okay, like this, and this is known as acantholysis. This is known as acantholysis. So you can see broken, right? Desmosome is broken and the keratinocytes, they move apart. So this is known as acantholysis. And if someone asks you what is acantholysis, you will say that there is loss of coherence or connection between the keratinocytes. And if we are discussing pemphigus vulgaris, it is suprabasal. And there is one more variant of pemphigus, that is pemphigus foliaceus. And in pemphigus foliaceus, the level of this acantholysis is subcorneal, right? Somewhere here, this is pemphigus foliaceus. So this is how things are differentiated, and at least for bullous pemphigoid and pemphigus vulgaris, one has to be very clear in the points of differentiation. This all point will summarize the important points you should know about these two conditions. And if you look at the clinical picture of bullous pemphigoid, and you can see the tense bully, of bullous pemphigoid, very easy to identify. And yes, as Raghu mentioned, we can also add oral, which is absent in bullous pemphigoid. It is present only in pemphigus vulgaris. So at least remember these few points out. Yes, bullous pemphigoid, elderly patient, tense bully. Yes, perfect. Right? So please remember this much. Now we come to another question. A pregnant lady with hyperpigmentation over face. So pregnant lady, yes, I think everyone can answer this. This is melasma, also known as plasma, right? So you can see this is typical presentation of melasma or plasma, right? Now another question. A young lady presents with vesicular lesions in the buccal mucosa and flaccid blisters over the skin. What could be the diagnosis? oral cavity involvement and flaccid blisters, the answer has to be yes, pemphigus vulgaris. So the moment you find flaccid blisters, oral cavity involvement, there is no other condition to entertain. It is pemphigus vulgaris. Oral mucosal lesions and flaccid. Yeah, this is pemphigus vulgaris. So you can see most of the blisters, they have already ruptured. You can see flaccid blisters, and sometimes there is rupture of the skin. This leads to denudation of. This is classical description for pemphigus vulgaris. Most of the things we have already covered for vulgaris. Now, what is this? Koebner's phenomena is not seen in. Any idea where we don't see Koebner's phenomena? Yes, everyone is correct. The answer is herpes simplex. Now, what is this Koebner's phenomena? Koebner's phenomena, everyone is correct. It is also known as isomorphic phenomena. It's also known as isomorphic phenomena. And iso means same, morphic means morphology or appearance. What happens here? Yes, Raghu, yes. So the sequence is normal skin, then trauma, right? And post trauma, there is appearance of lesions over that normal skin. Clear? So yes, so normal skin, trauma, and appearance of lesions of that particular condition, whatever is in discussion. So we have three conditions: lichen planus, psoriasis, and vitiligo. So suppose if we are discussing about psoriasis, it means there will be appearance of psoriatic. Whatever the condition we are discussing, if there is any over the normal skin, that will promote the appearance of new lesions. And this picture you can see. So patient with psoriasis went for tattoo, and later on that area developed psoriatic lesions, and you can classically see two important things. You can see erythema, that is redness, and you can see silvery, classical presentation for psoriasis. So this is actually Koebner's phenomena or isomorphic phenomena, but this is not specific only to psoriasis, lichen planus, as well as vitiligo. Yeah. So this is just to define what isomorphic or Koebner's phenomena. And in relation to this, sometimes there is one more word, and that is known as inverse Koebner's phenomena, reverse Koebner's phenomena. What happens here, right? So what happens? There are lesions, then trauma, and disappearance of lesion. This is inverse or reverse Koebner's phenomena, where injury might lead to disappearance of lesions, can be seen in psoriasis. Right? So there are two terms, but please remember Koebner's phenomena, and that is not specific. Now coming to next question. A young male presented with pruritic, flat-topped, polygonal, shiny, violaceous papules on flexural aspects. What is the likely diagnosis? Very good. So this is a classical presentation for lichen planus, and one must remember the 5 P's of lichen planus. What are those 5 P's? Everyone is right. This is lichen planus. What are those 5 P's? Okay, yes. See reticular pattern in oral cavity. Good. The regime in nail. So what are the 5 P's of lesions of the skin lesions of lichen planus? One is of course the color, that is purple, or what we say violaceous. The second P is pruritic, means there is severe itching. Then third P is plain topped, means flat from above. And fourth P is polygonal, right? So geometrical configuration can be polygonal. And what is the fifth P? Papule. Very good. So what is this word papule? Any idea what is this word papule? Anyone? Papule. See, again there are two terms. One is papule, another is plaque. The size of papule is than 1 centimeter, plaque is 1 centimeter, and we define them as raised in clear. Papule means that the size of the lesion is going to be less than clear. These are the 5 P's of Lichen planus, and you can see classical Lichen planus, especially involving the flexors area. So you can see this is the flexor aspect of the forearm, right? And there might be lacy markings in oral cavity associated. Marking, and yes, flexor aspect. And second is, you can see Victim try on the top of the lesion stripe. Then third, these are additional features which you should remember. Right? Please remember this much for Lichen planus, and it is very easy to make a clinical diagnosis in planus. Now, coming to the next question. Yes, civate bodies, right, Nidhi? Coming to the next question. Male presented with painful grouped vesicular eruptions, and he have a history of similar lesions in past 1 year. What can be the diagnosis? Very good, very good. Everyone is right. This is herpes simplex virus 2, and the condition is actually herpes genitalis. This condition is actually herpes genitalis, and if you look at the image, you can appreciate grouped vesicular lesions. They are in a group, and importantly, you can see there is redness. There is redness around the lesions, so this is known as erythematous phase. So related to surrounding all vesicles, there is redness. And redness, you can see redness all around the vesicle, and they are always in a group. So important is for herpes, the important thing is that group vesicles, we discussed less than 1 centimeter, clear fluid filled lesion. Okay. And there is erythematous phase, so redness can be seen. Okay. And they mostly we find all these vesicle groups. That is very specific for herpes. And since this is a high friction area, so at times there might be rupture of these vesicles, and patient might come to us with ulcers. Pulsion, yes, painful in Ducray, but it can be in multiple. Very good, Patricia. Right. So this is very classic of herpes genitalis. And what drug you need to give? Any idea what drug you need to give? Isoclone. Yes, right, Pratik. So this is herpes genitalis. Now, next question. A young male patient presents with mild urethral discharge. What should be given to treat such a patient? I think one should just make sure that whether it is 1 gram or 1 milligram. Of course, it is single oral dose. This is SOD, that is single oral dose, right? So the answer is 1 gram single oral dose or 1 gram stat. Now, what is the clinical condition? What is the diagnosis? You tell me, what is the diagnosis? Anyone, what is the diagnosis? You are treating the patient rightly, but you should know what's the diagnosis. Anyone? Diagnosis? See, urethritis is a broad term, right? Urethritis or urethral discharge is a broad term, and in this, very good, in which we discuss two conditions. One is gonococcal urethritis and another is non-gonococcal. Yeah. So gonococcal, as the name suggests, it is because of Neisseria gonorrhoeae, and non-gonococcal is cause of chlamydia. Right? So this is a classical picture of non-gonococcal urethritis, right? And how we clinically differentiate? We look for the kind of discharge. In gonococcal, it will be, in gonococcal, what kind of discharge you see? Purulent, right? Purulent, thick, yes, purulent, thick. Whereas in case of chlamydia or non-gonococcal urethritis, the discharge is watery, thin. So the kind of discharge actually tells us about the probable diagnosis. So here, since it is mild urethral discharge, we can assume it to be a case of non-gonococcal urethritis, which is caused by chlamydia, and we will give azithromycin 1 gram single oral dose. Yes, of course, for gonococcal we will give cefixime. So this is in short about the urethral discharge. I think all of you must be knowing what in syndromic approach of STIs, what kit we give for urethral discharge. What kit? Yes, gray kit 1. Very good. Gray kit 1. And what drugs it contain? Yeah. So this is for urethral discharge. Now, moving forward to next question, Auspitz sign. What is this Auspitz sign and where we see? Yes, this is seen in Psoriasis vulgaris. Now, what is this Auspitz sign? Any idea what is Auspitz sign? Very good. So we know that in psoriasis there are silvery scales. There are silvery. If you try to remove these silvery scales, this will lead to pinpoint. Yeah. So the simpler explanation for Auspitz sign, removal of the scales leads to pinpoint bleeding. So classical, you can see pinpoint bleeding after removal of scales. So this is Auspitz sign, very suggestive of psoriasis. And if we go for the exact process, then you can recall one Gratis test, right? And when we remove the silver scales with the edge of a slide, there is appearance of alkalis membrane, and once this membrane is also removed, we will find the pinpoint bleeding points. So this is the actual description, but in this Gratis test. So, but in shorter terms or in simpler words, we will say that removal of silvery scales will lead to pinpoint bleeding, and that is also psoriasis. Perfect. Now coming to next question, spaghetti and meatball appearance. Very good. So this clinical condition is Psoriasis versicolor, or also known as tinea versicolor, which is caused by Malassezia furfur. And what actually we see here, we will see rounded forms. Okay. These are the meatballs, and we will also see the elongated forms, which are actually the spaghetti. Spaghetti and meatball appearance, and sometimes it is also known as banana grape. Just because of those looks, it is also known as banana and grape appearance. Yes, right. So spaghetti and meatball and banana and grape. Now, next question. There is, we need to correct this. We placid. So there is a history of placid bully with oral ulcers, and if you do microscopy, what you will see? Yes, very good. The condition is perfect. The answer would be acantholytic cells. Diagnosis, clinical diagnosis, pemphigus vulgaris, and if we prepare a Zank smear, we will see an acantholytic cells. So now, what acantholytic cells look like? So you will see a rounded cell, and you will see a large acantholytic. Okay, so these are actually the keratinocytes. Yes, Solon cells. Yes, on Zank smear. Zank smear. So the keratinocytes, they become swollen, they are rounded, and these are known as acanthocytes. And in this image also, you can clearly see the acantholysis. This is acantholysis. You can see that there is so much of gap between the keratinocytes. Normally, the keratinocytes in the epidermis, they are very tightly packed because of desmosomes. But here you can see there is gap, and this is known as acantholysis. So this is acantholysis, and since it is seen within the epidermal layer, so it is known as intraepidermal acantholysis. Clear? So acantholytic cells on Zank smear in a case of vulgaris. Next question. There is a family history of asthma. Now the patient has presented with itching in cubital fossa and popliteal fossa. Most likely diagnosis. Now here you have to this one word, asthma. Yes, very good. So the moment you find the word asthma or any allergic condition, the answer is atopic dermatitis, and you can see there is so much of itching in the popliteal fossa. There is so much of itching that led to coriation of the skin. This classical picture of atopic dermatitis, and since there is so much of itching, this condition is also known as itch. So itch disease, and there is always a family history of asthma. And apart from that, what else you can see, there is one important finding in lower eyelid. What is that? This atopic condition, so type 1 reaction. What you will see in eyelid, especially in lower eyelid, you will see an morgal line, And right. And how the diagnosis is made? Any idea how diagnosis is made? Any Morgan folds? The diagnosis is always clinical, right? So you have to take the history, and based on that only you will make the diagnosis. And we use one criteria is Nifin and Ajka criteria. So the diagnosis of atopic dermatitis has to be always to be clinical based on the presentation of the patient.